Hi friends, in today's video we're going to talk about a pneumothorax, and if you like this video make sure to give it a thumbs up and subscribe to my channel. I come out with new nursing content every week for nurses, nursing students, and pre-nursing students to help you through your nursing journey. Also, make sure to check out all the free study guides below that I have and resources, as well as the NCLEX study guide. All right, let's get into it. So a pneumothorax is a collapsed lung. It is a collection of air in the space around the lung. The air buildup puts pressure on the lung so it cannot expand as much as normal. It occurs when a parietal or visceral pleura is breached and the pleural space is exposed to positive atmospheric pressure. This pressure is normally negative. There's also a spontaneous pneumothorax, which occurs with the rupture of what's called a bleb, and there is an open pneumothorax, which occurs when an opening through the chest wall allows the entrance of positive atmospheric pressure into the pleural space. It is also diagnosed by a chest X-ray. So there are various classifications for a pneumothorax. So we have a simple pneumothorax, which is a spontaneous pneumothorax that occurs when air enters the pleural space through a breach of either the parietal or visceral pleura. There's also a traumatic pneumothorax, which is when air escapes through a laceration in the lung itself and enters the pleural space or from a wound in the chest wall. And there is a tension pneumothorax, which occurs when air is drawn into the pleural space from a lacerated lung or through a small opening or wound in the chest wall. So the pathophysiology includes negative pressure. So negative pressure is required to maintain lung inflammation. Then there is some sort of breach to this. So when either the pleura is breached, air enters through the pleural space, and then there is a collapse. So when positive pressure has entered the pleural space, the lung or portion of it collapses. So this is a nice pathophysiology chart. I love these charts because it just puts everything into a nice little condensed format. So we have over here a pneumothorax, which there's a couple different ones. So the primary pneumothorax do here, and then a secondary pneumothorax. And this leads to the disruption of the parietal or visceral pleura, which is what we just talked about. And that's going to lead to different mechanisms. So there could be irritation of a highly sensitive parietal pleura. There could be injured tissue, which forms a one-way valve into the pleural space. There could be air that enters or fills the pleural space due to physiological or negative pleural pressure, but cannot leave. And this leads to increased pressure in the epilateral hemithorax. So, and then also air between the visceral and pleural pleuras separates the two layers, showing the visualization of a pleural line. So these are kind of all the things we talked about, just in a little more detail. And then anything that is red is going to be the X-ray findings. So this is what leads to the visible visceral pleural line. They may also see in epilateral rib slaying, which is an increased space between the ribs, or a depressed hemidiaphragm. So again, you won't need to know in nursing school how to read an X-ray or the different things you'll see on an X-ray, and there is this really great chart showing the X-ray, and the different things that you would see are pointed out, but you don't need to memorize this. This is just a fun chart. I really like this chart, and it is kind of interesting to look at. So, and then we can see for signs and symptoms and lab findings, those are all going to be in green. So we can see why certain mechanisms lead to certain signs, symptoms, or lab findings. So, the no air entering in the affected lung here we can see that that's going to lead to a decreased chest wall expansion. A lack of lung markings beyond the pleural line is something that we will see in the x-ray. You don't need to worry about that, but that's going to lead to decreased breath sounds and dyspnea. We can also see, if we follow all these different mechanisms, so, increased pressure in the ipsilateral hemothorax is going to lead to a medial sternal shift from the affected side, which is going to lead to potential contralateral lung impingement, which is going to lead to impaired gas exchange in the affected areoli, which is going to have ventilation and perfusion problems, and is going to lead to hypoxia, which is going to lead to decreased blood oxygen level, tachypnea, and increased respiratory rate. And then we can also see, again, coming back to that pressure in the ipsilateral hemothorax, we can follow it over here. It's going to lead to compression of the superior vena cava and inferior vena cava, which is going to decrease blood return to the right atrium, and the blood backs up into the venous system, which is going to decrease the cardiac output and lead to increased jugular venous pressure, tachycardia, and hypotension. So there are a lot of things in this chart that you don't need to memorize, specifically the x-ray and some of the mechanisms. We went over the mechanisms that you need to know, but this is kind of a nice way to tie it all together. So then it also depends on, remember we went over that there are different types of a pneumothorax. So this is the primary spontaneous pneumothorax, and this is the same thing, pathogenesis and clinical findings. So, we can look over here that, these are some of the pathophysiology is going to be up here in the blue. So, thoracic endometriosis, tall, thin males, genetic factors, malnutrition, these are all risk factors, leads to a structurally compromised lung parenchyma. Mechanical forces in respirations create blebs or bullae, which cause a spontaneous rupture of those blebs, and that leads to a sudden onset chest pain. These are also, so these are kind of, genetic factors. And then we also have some more over here. So smoking, ischemia, thoracic endometriosis, which can also lead to inflammatory disruptions of the mesothelial cell layers and visceral pleural, which again leads to the same thing. It brings us down here. So you have your sudden onset pleuric chest pain and your tachycardia. So the primary spontaneous pneumothorax is the present or introductory of air into the pleural space in a patient without a diagnosed or clinically apparent lung disease. Communication occurs between the alveoli and pleural space. Alveoli pressure is greater than the pleural pressure, and air from the lung enters the pleural space. This leads to air separating the chest from the lung and increase intrapleural pressure. So when the chest separates from the lung, we're going to see a decrease of chest wall expansion, an increase of resonance to percussion, a decrease of absent tactile fremus, and a decrease of breath sounds. And we'll see that pleural line on a chest x-ray. And that leads to a tension pneumothorax. And for that, we'll see hypotension, jugular vein distension, and pulsus paradoxus. Also, this will lead to air leaking into the subcutaneous tissue, and we'll see that subcutaneous emphysema. If we come over here, so increased intrapleural pressure will lead to small areas of lung collapse under unopposed intrinsic elastic recoil, which is going to lead to decreased lung compliance and increased work of breathing, and we're going to see that accessory muscle use and tachypnea. And also will have decreased blood flow to areas of electrolysis is maintained while ventilating decreases, which shunting, and there's a mismatch in VQ, and we'll see decreased in ROT sats and sudden onset dyspnea and tachycardia. So again, a lot of stuff going on here. Main points to know are those signs and symptoms and what a primary spontaneous pneumothorax is. Okay, so different causes. So We went over a lot of this, but we have the rupture of the bleb. So that is with that spontaneous pneumothorax. And this happens in an apparently healthy person, and there's no signs of trauma. And it's due to the rupture of the air-filled bleb. There's also blunt trauma, like a rib fracture. This causes a traumatic pneumothorax. There's an invasive procedure. So a traumatic pneumothorax may occur during invasive thoracic procedures in which the pleura is inadvertently punctured. And we may have a penetrating chest or abdominal trauma, such as a stab wound or gunshot, and that would cause a traumatic pneumothorax. So clinical manifestations that we're going to see are pain, usually sudden, minimally respiratory distress. So they may only have a small amount of respiratory distress with slight chest discomfort and tachypnea. We may see dyspnea, so due to pain, the patient can have difficulty breathing. We may see central cyanosis from severe hypoxemia. The chest expansion in simple intention pneumothorax is decreased. Our breath sounds are usually diminished or absent in both simple and tension pneumothorax, and tracheal alignment. So in a simple pneumothorax, the trachea is midline, while in a tension pneumothorax, the trachea is shifted away from the affected area. And that is a key point. You'll probably see a question about that on your test. So if the trachea is shifted away from the affected side, that's going to be a tension pneumothorax. And remember, it's the opposite, because whatever side that tension pneumothorax is on, the trachea is going the opposite way. So assessment and diagnostics. So a thoracic CT may be ordered because it's more sensitive than an X-ray in detecting thoracic injuries, lung contusions, hemothorax, or pneumothorax. A chest X-ray may be ordered because it can reveal air or fluid accumulation in the pleural space and may show a shift of medial statal structures like the heart. They may order some ABGs. So depending on the compromise of lung function and altered breathing mechanics, the ability to compensate of the body, the pressure of carbon dioxide might be elevated. We can also look at a thoracentesis. So the presence of blood or ceosanguinous fluid indicates a hemothorax. And they may also look at the hemoglobin, which may decrease, indicating blood loss. So medical management for these patients include a chest tube. It's usually inserted near the second intercostal space to drain the fluid or air. And the patient with jeopardized gas exchange chest tube insertion may be necessary to achieve lung re-expansion. The priority is to maintain the airway, breathing, and circulation. And the most important intervention is to focus on reinflating that lung by evacuating the pleural air. Patients with a primary spontaneous pneumothorax that is that is small and minimal symptoms may have spontaneous sealing and lung re-expansion. We need to maintain a closed chest drainage system. So we need to be sure to tape all connections and secure the tube carefully at the insertion site with adhesive bandages. We want to regulate the suction according to the chest tube system directions, and usually the suction does not exceed 20 to 25 for negative pressure. Monitor a chest tube unit for any kinks or bubbling, as this could indicate an air leak. We do not want to clamp the chest tube without a physician's order because clamping may lead to a tension pneumothorax. We can use an auto transfusion, which involves taking the patient's own blood that is already draining from the chest, filtering it, and then transfusing it back into the vascular system. And we may use antibiotics to combat infection or oxygen therapy given at a high concentration of supplemental oxygen to treat hypoxemia. So surgical management can include a thoracotomy, It's a surgical procedure in which a cut is made between the ribs to see and reach the lungs or other organs in the chest or thorax. Typically, a thoracotomy is performed on the right or left side of the chest. An incision on the front of the chest through the breastbone can also be used, but it is rare. The chest wall is surgically opened to remove the blood or air trapped in the pleural space. So our nursing assessment should look for that tracheal alignment, expansion of the chest, breath sounds, and percussion of the chest. Our nursing diagnoses can include things like acute pain related to positive pressure in the pleural space, ineffective breathing patterns related to respiratory distress, ineffective peripheral tissue perfusion related to severe hypoxemia, and anxiety related to difficulty in breathing. Nursing care planning goals can include relief of pain, adherence to prescribed pharmacological regimen, establishment of normal active respiratory patterns as evidenced by absence of cyanosis, demonstrate increased in perfusion, and be relaxed and report anxiety to reduce to manageable levels. Our nursing interventions will include re-expansion, so the patient will be instructed to inhale and strain against a closed glottis to re-expand the lungs and eject the air from the thorax. We'll also use a sterile covering, so the opening is plugged by sealing it with a gauze, and oxygen saturation will be monitored. So evaluation, and this again depends on our patient outcomes, but could be things like pain is relieved, adhered to prescribed pharmacological regime, established a normal effective respiratory pattern as evidenced by absence of cyanosis, demonstrated increased perfusion, and the patient is relaxed and reported anxiety is reduced to a manageable level. So our discharge and home care guidelines should include asepsis, so the site of incision should be handled aseptically to avoid occurrence of infection. Medication education should be taught around that medication should be taken as prescribed and antibiotics should not be stopped until they are completed. Follow-up appointments should be made, and activity, so alternate between rest and activity to avoid overexhaustion and difficulty in breathing. And our documentation should include things like client's description of pain, acceptable level of pain, prior med use, respiratory pattern, breath sounds and accessory muscle use, laboratory values, use of respiratory aids and supports, pulses and blood pressure, nature, extent and duration of problem, level of anxiety, description of feelings, awareness of ability to recognize and express feelings, plan of care, teaching plan, response to interventions, treating, teachings and actions performed, attainment of progress towards desired outcomes, modifications to the plan of care, and long-term needs. So that is the video on pneumothorax. I hope you guys found this helpful. Make sure to check out all the free resources down below, as well as the NCLEX study guide, and give this video a thumbs up. I'll see you next time. Bye.